Good morning. I want to thank the organizers for giving me an opportunity to speak here. And as a local resident, let me welcome you to Nashville and hope you enjoy our great city. It is a new experience for me to attend a meeting like this and yet sleep in my own bed. And I'll say it's highly recommended. So if you ever get a chance to try it. I'm going to talk today about an approach that we've developed over the last 10 years or so at Vanderbilt, really talking about the utilization of cytogenetic and molecular testing in hematologic malignancies, and talk specifically about how over the past few years we've applied this approach to next generation sequencing to ensure that we're ordering these tests in the right situations every time. I'm a hematopathologist, I'll confess that at the outset. And one of the things that really attracted me to hematopathology is the multidisciplinary approach to diagnosis that we see in these diseases. And obviously, we still use traditional cytomorphology, but we also get to use immunophenotyping approaches like immunohistochemistry and flow cytometry to diagnose these diseases. And increasingly, also using cytogenetic and molecular techniques, traditional karyotyping, fluorescence in situ hybridization, and more molecular testing in looking at these types of diseases. The purpose of all this multidisciplinary testing is to make it the appropriate diagnosis. But what's really been neat over the last 20 years or so is that with the classification schemes that have come out, we use now cytogenetic techniques and molecular techniques to actually classify these diseases. And this classification then drives the prognosis. As you've seen in the previous two talks, for example, we know that the patients that carry inversion 16, for example, traditionally have a better prognosis. But you can see that even from that talk that beyond even the things that we use for classification, there are additional cytogenetic and molecular abnormalities that may drive our understanding of prognosis of a particular case above and beyond that. In hematologic malignancies, the prognosis often drives therapy because the clinical approach to these patients is also often based on risk stratification. But in addition to that, we have more and more now targeted approaches to therapy where patients that carry particular abnormalities or particular mutations now become eligible for targeted therapies, really taking a personalized approach to their disease. And in hematologic malignancies, which makes them unique amongst many different types of cancer, we can actually use these techniques to monitor the response to therapy as well. So you can see that this multidisciplinary approach plays a role not just in the diagnosis of the disease, but also in the prognosis, risk stratification, therapy, and monitoring of a patient going forward. And so it's really important that we utilize these tests appropriately and correctly in order to make a diagnosis. But given that the presence of so many different diagnostic modalities is a bit of a double-edged sword. So in addition to the power that it gives us to characterize these cases, it can also create a lot of challenges and confusion when it comes to deciding what test to order in a particular case. So the traditional way that lab tests are ordered is what I call the catapult model of pathology. Basically what you have is you have a clinician, and a clinician has a patient, they draw a sample of some kind. They catapult that order with the sample over the wall that stands between the clinician and the laboratory. The laboratory receives that, performs the order test, and back over the wall they send a result without much interaction between the clinician and the laboratory. The clinician then is left to get all of these results, collate them, apply them to the particular clinical case, and interpret those results to take clinical action. I want to illustrate the challenges that are associated with this traditional approach when we apply all of the modern techniques that we have. Here's an example case of acute leukemia. A patient presented to the emergency department with leukocytosis. The smear showed that there was 69% blasts. The clinician ordered a bone marrow biopsy, and the traditional way that this is done is the clinician at the time of ordering the biopsy orders all the necessary tests. And so you can see that there was a series of 9 different tests that were ordered on this case. that went to 5 different laboratories, and all came back with different results. The clinician then had to receive all of these results and interpret them by him or herself. Initiate chemotherapy, and then, because this is a hematologic malignancy, then the response to therapy is measured by doing a repeat bone marrow biopsy at 14 days, and again at 28 days, and again several months later. So this is associated with a lot of challenges. The clinician who's faced with this clinical situation has to make a decision based on a very broad differential. They don't know necessarily that this is acute myeloid leukemia. It could be lymphoblastic leukemia. It could be mantle cell lymphoma. It could be any number of things. And so they have to make a decision about which test to order before they really know what the diagnosis is. They're also faced with a very large test menu, and one that is increasing in size, as we've seen already this morning, as more and more diagnostic modalities and tests appear. But there are very few guidelines about how to apply these tests in any given clinical situation. These tests go to multiple laboratories, as we see here. They come back as multiple asynchronous reports. They all come back at different times. And the interpretation of these tests is complex. Sometimes it's not a simple positive or negative. The interpretation of these is often context dependent. There are interactions, as we've seen already this morning, between the different testing modalities, where the results of one test inform how you interpret the results of another. And then there are multiple iterations. So not only does the clinician have to decide what test to order at diagnosis, they have to decide what test to order when the patient comes back in 14 days and 28 days and so forth. And so you can see that there are a lot of challenges to the modern oncologist as they're faced with decisions about what test to order in what situation. This leads to some real limitations of what I've described as the traditional approach to ordering. We're very aware of poor utilization problems. Everyone that I talk to that works in a cytogenetics or molecular lab will tell me that they see a lot of overutilization. They see a lot of testing that's ordered that's probably inappropriate. What's perhaps not as well appreciated is underutilization, because we don't see what isn't ordered, right? But it's also true, and studies have shown, that there are many cases in which things that should be ordered haven't been, simply because they didn't know the diagnosis up front. This poor utilization leads to suboptimal test performance. Overutilization reduces positive predictive values. You end up with false positives and false negatives. There's also increased costs associated with that, and these are some of the most expensive tests that we perform in the laboratory. Because of all the tests that are ordered, there are issues tracking the status of those tests for clinicians, and there's sometimes misinterpretation or misapplication of results simply because of the sheer amount of data that they're faced with. So at Vanderbilt, what we've done is taken what we call a diagnostic management team, or DMT, approach to test ordering. And a DMT, really at the heart of it, is a collaboration between pathologists and laboratorians, experts in testing, with the clinicians who are ordering and using the test results. And also with informatics experts, which help us to figure out unique unique technologies which allow us to sort of smooth the interactions between the laboratory and the clinicians. This group of individuals is tasked with addressing these challenges in test ordering and interpretation in situations like hematologic malignancies where we have complex testing. The goals of a hematopathology DMT are to create guidelines, algorithms, and processes to ensure that the right tests are ordered on the right sample, on the right patient, at the right time, every time, to meet the individual clinical needs of that patient. And also to create integrative narrative reports that really ease test interpretation for the clinician that has to deal with a lot of data and figure out what that data means for an individual patient. The informatics folks then have developed tools and processes that facilitate that communication between the clinicians and the laboratory in order to make sure that this process occurs as it should. So I illustrated the traditional way that tests have been ordered. The DMT process is what you see below then. The DMT inserts itself between the clinician and the laboratory on the left-hand side to ensure that the right tests are ordered. And for that, we use what we call standard ordering protocols, which I'll describe in a second. Then inserts itself between the laboratory and the clinician on the right-hand side and produces comprehensive reports, which ensure that the clinicians get all the data and have some guide to interpret the data for that patient, with enhanced communication easing the interactions between the DMT and the clinician in the laboratory. So I'm going to focus the rest of this talk on these standard ordering protocols and how we've designed systems to ensure that the right tests are ordered on the right patient at the right time. These protocols were designed by teams of hematologists, the clinicians, and pathologists from the laboratory, working together to design protocols that are specific to particular types of disease and specific to the stage of therapy at which a particular patient is at. Importantly, these ordering protocols are not anymore applied by the clinician at the time of ordering, but are rather applied by the pathologist after they view the bone marrow biopsy, or at least get an initial look at it. We try to the extent that we can to base these on evidence that exists, but oftentimes there isn't any evidence to tell us what to order at a particular time, and I'll talk about how we dealt with that problem in a little bit. The principles that we used is that tests should be ordered at diagnosis if and only if these tests are useful for making a diagnosis or classifying the disease, saying something about the prognosis of this disease in that patient, for later monitoring of therapy, or for decisions about therapy. At follow-up, that is a subsequent bone marrow biopsy, these tests should be ordered if they were positive at diagnosis. That seems pretty intuitive, but you'd be amazed how often that doesn't happen. If they are sensitive for residual disease detection, and if there's more than one modality that can test an abnormality, that we choose the most sensitive of those testing modalities to assess for residual disease. Now, importantly, we still allow clinicians to order tests, what we call a la carte, outside of the protocols, because they understand things about the patients that we may not. And so we always leave them the option in complicated patients to order tests a la carte if they need to. This is an example of what one of our standard ordering protocols looks like. It looks more complex on the screen than it actually is. What you see in blue boxes is pretty simple questions that a pathologist can ask about a particular case that leads you through a stepwise process of identifying the right test to order in that patient at a particular time. What's really neat about these algorithms is that they can also be computerized. And so we've set them up so that we can answer questions on a computer screen, and it will automatically run an algorithm that will tell us the right test to order in the right situation. So we started this back in 2009, a group of us, and we've been doing it, or 2010, I guess, with the first SOPs rolling out on actually Valentine's Day of 2011. That's how we remember it. And you can see the changes that occurred over the first couple of years. What I want you to focus on is notice that what we deemed unnecessary tests, things that were ordered previously but shouldn't have been, that the number of unnecessary tests went down 45% in the first year, 60% by the end of the second year. Omitted tests, that is things that should have been ordered but weren't, went down by 50% the first year, 70% the second year, leading to a total decrease in the total tests that ordered per marrow by around 10% the first year and over 20% the second year. This drove the cost of testing on bone marrow biopsies down by 25% in the second year, and we calculated that we were saving patients and payers over $1 million a year at Vanderbilt by ordering just the right tests on every single bone marrow biopsy. Now, importantly, what you can also see is that the number of positive tests also increased. So whereas at baseline, only 17% of our tests came back positive, after the first year, there was a 34% increase and over a 50% increase the second year in the percentage of tests that came back positive. And what that tells us is that the tests that we were no longer performing are those that were least likely to be informative, and that the positive predictive value of the tests that we perform is actually going up. Now, what's important about this system is that it can continue to learn. So I told you before that in many cases there wasn't great evidence to support decisions that we were making in these standard ordering protocols. And so it was important for us that we continually analyze data and use the DMT system as a way to generate data that then we could use to refine the SOPs and make better decisions going forward. And this is a form of what some people have called a rapid learning system, in which you use patient data that's acquired every day on real patients, analyze that data, and use it to transform subsequent care. So in our case, we started with initial standard ordering protocols. Over the years, we've collected data on results and on utilization of tests. We've analyzed that data and used it then to revise the standard ordering protocols to refine those processes over time. So here's an example of how the DMT system has learned to do better. So in the initial SOPs that we designed back in 2011, on patients that came in with bone marrow failure syndrome, suspicious for myelodysplastic syndrome, for example, we were doing a karyotype and a FISH panel on every case. In our hands, and this may be different from laboratory to laboratory, but in our hands at least, we found that the FISH testing was actually pretty redundant, that it was very uncommon for us to detect abnormalities by FISH that weren't present by the karyotype. And so when we revised the SOPs, we left the FISH out. Since we got all the information we needed from karyotype, we simply did karyotypes going forward. And you can see the results of that after the first SOP, there was very little change in utilization, but after the second SOP, that went way down. And so that is an example of how we were able to refine the protocols over time to get better and better at performing the right tests. Now, the topic that I promised I would discuss today actually has to do with next-generation sequencing. And this is a new, relatively new technology, not new to anyone in this audience, but something that we started doing back in 2015 on myeloid malignancies. And we started using a panel that had 37 genes that were commonly mutated in myeloid malignancies, including acute myeloid leukemia, myelodysplastic syndrome, myeloproliferative neoplasms, and MDS-MPN overlap disorders. And the question that we had at the outset when we started this test was, how do we fit this into the existing SOPs? How should we use this test, and in what circumstances should it be ordered? It was pretty simple, at least the first decisions, because we knew that the genes or the mutations that we would identify using next-generation sequencing would be things that would help us classify, that would help us guide prognosis, targeted therapies, and therapy monitoring for bona fide cases of AML, MDS, and MPN. Certainly, there's plenty of evidence out there that suggests that they're useful for those cases. What was a little bit more of a challenging were cases where the morphologic diagnosis was not clear-cut. So those cases that we see that are sort of rule out MDS, and either there's some maybe minor changes in morphology that may suggest MDS or no changes, and yet there's clinical concern for disease. And the question is whether it would be useful to perform NGS in those cases. The problem with that is that this concept of mutations of unclear significance, there is this well-known phenomenon of age-related clonal hematopoiesis, and these are low-level mutations, mostly in MDS-related genes, in patients that have no other evidence of myeloid malignancy. And these are present in about 10% of healthy patients over the age of 65, which is coincidentally the prime age for most of these myeloid malignancies. Now, these are not benign changes necessarily, because they do seem to confer an increased risk of subsequent hematologic malignancy and paradoxically also cardiovascular disease. The way that this has been categorized is when you have a patient that has no cytopenias, for example, but carries one of these, we call it clonal hematopoiesis of indeterminate potential, or CHIP. In the presence of cytopenias, you'd call it clonocytopenias of undetermined significance, or CCUS. And it was unclear to us what to do with these cases. This was what the real challenge was. And so we made an initial decision based on conferring between the hematopathologists and the clinicians that dealt with these patients, that what we would do is that we would only use NGS testing, this particular panel, in those cases where it was morphologically diagnostic of disease. So we decided that we were just going to use it in the slam dunk cases of AML, MDS, MPN, and so forth, at first diagnosis or initial presentation, at the time of progression, that is MDS progressing to AML, for example, or when patients have had a complete remission and then relapse. For any other indication, if it's going to be used, for example, in a situation where there's no morphologic evidence of disease, but a clinician wants to use it to rule out disease, it had to be ordered a la carte by the clinicians. And that's the decision that we made initially. The question we had, though, is that the right decision? And that we didn't feel like there was sufficient data at the time. And so we've collected data then over the subsequent years to decide if this was the right approach or not. So the data I'm going to show you is collected between 2015 and 2018. It represents 1,118 NGS panels run on bone marrows of patients at Vanderbilt. Of those 1,118 tests, 70% of them had at least one mutation. And the question we asked then is restricting testing to morphologically definitive bone marrow samples, is that the most effective use of this testing? Or is there some utility for NGS in cases that aren't morphologically positive? Here's how the data breaks down. Most of the cases that we saw, over half of them were acute myeloid leukemia or myelodysplastic syndrome, with some NPNs and overlap disorders as well. About 20%, just under 20% of the cases were cases that were ordered a la carte by the clinicians in morphologically normal, quote-unquote, normal bone marrows. More than half of these were cases where the clinician was suspicious for myelodysplastic syndrome. About a quarter of them were rule-out myeloid proliferative neoplasm cases, with the rest of the cases being patients who had a prior diagnosis, but now whose bone marrow was negative after therapy. And this is the data represented in sort of a complex manner, but let me walk you through what this shows. On the left-hand side, you see the 37 genes that are present in our panel. They are ordered from top to bottom by the frequency of the mutations, and as you might expect, so TP53 is the most common mutation that we see in these diseases, and then going down in order. What you see on the top is then the cases that are morphologically positive. These are what I called the morphologically slam dunk cases. So acute myeloid leukemia, myelodysplastic syndrome, MPNs, and MDS MPNs. And over here you see those morphologically negative cases, the ones that were ordered a la carte, in patients that had a prior history of disease where there was rule-out MDS or rule-out MPN as the indication. What you can see is the mutations that you see are the types of things that you would expect. The frequency of things that we see in AML are things like P53, FLT3, NPM1. In MDS, you see more of the spliceosome mutations like SF3B1, for example, or U2AF1. In the MPNs, you see JAK2, you see CALR, you see MPL, as one would suspect. Across the top, what you can also see is the number of mutations that we saw in each case. And you can see that these bars are quite high in patients with bona fide disease. And you can see that there were very few mutations in patients that were morphologically negative. In fact, if you look at it, more than 80% of cases that were morphologically positive for disease carried a mutation, while just over 10% of the morphologically negative cases did. If you break those down by the types of disease, they're most frequent in MDS and MPNs, where almost every case had some mutation, but much less frequent in those cases where you're ruling out MDS, for example, or ruling out MPN, but were morphologically negative. The types of mutations that you see in these cases are the things that you would expect in MDS. They are ASXL1. TET2 is actually the most common one. There were 3 patients actually where we saw GATA2 mutations, and this is not by accident. This is patients that actually carried germline mutations, and the bone marrow biopsy was performed as surveillance for myelodysplastic syndrome, for example. So what did we learn about these particular patients then? The 17 patients that had mutations in the morphology negative rule-out MDS cases. One thing that we learned is that these patients tended to be older, with an average age of around 65, as opposed to all the other cases where the patients were a little bit younger. And that correlates with the age that you see age-related clonal hematopoiesis. 2 of these 17 had cytogenetic abnormalities that were indicative of MDS. So the diagnosis of MDS would have been made by WHO criteria, even if we did no NGS at all. And so those certainly were cases that are bona fide MDS. So I talked about the germline mutations in GATA2. The remaining 12 mutations, 8 of them were low-level mutations that were probably suggestive of age-related clonal hematopoiesis. All of them had variant allele fractions less than 20%. There were 4 cases, though, that had higher variant allele fractions, but as we followed them over time, we found that they had stable counts, and they didn't convert, at least in any cases that we were aware of, to bona fide myelodysplastic syndrome, for example. In the morphology negative rule-out MPN cases, there were 4 cases that carried mutations. All of them were more than 50 years old. All of them had variant allele fractions less than 10%. And again, these likely represent sort of clonal hematopoiesis of some kind, but are not indicative of an MPN. 2 of them, interestingly, had very low-level mutations in JAK2, and so that raises the question of whether this was just a very early presentation of MPN, or whether that was a JAK2 that was truly age-related clonal hematopoiesis. So as we look at these cases, then we can draw some conclusions, I think. One is that the DMT approach is effective. We use it to optimize test utilization practices as improve test performance at our institution. And so we're really excited about the ability to apply this type of approach to NGS sequencing as well. We found that the decision that we made that we would limit this to marrows with morphologic evidence of disease has some basis in fact, that in fact these mutations were much more frequent in morphology positive cases than they were in morphology negative cases. And most of the mutations that we see in morphology negative cases are associated with age-related clonal hematopoiesis. So you can, one possible interpretation of this data is that the utility of NGS testing in morphologically what we call rule-out bone marrows may actually be sort of limited, that in most cases it doesn't add anything to the morphology and other evaluations of this disease. But you have to think about a couple of caveats here. One is, you can ask the question of whether the diagnosis of age-related clonal hematopoiesis is actually clinically useful, given that patients that carry these mutations are at greater risk for developing a subsequent hematologic malignancy. Would this cause a clinician, for example, to maybe monitor this patient more frequently or to watch them clinically more carefully, or to think about the risk of cardiovascular disease in these patients, for example? One sort of idea that I like to apply to these is in the clinical world, we use this statistic, which is number needed to treat, the number of patients that need to be treated with a drug in order to get clinical benefit. I've sort of twisted that to think about the number needed to test. So in order to catch one case of age-related clonal hematopoiesis in these rule-out MDS bone marrows, you'd have to test approximately 9 bone marrows. And so that's something to think about as you think about cost-benefit analysis of doing that approach. In rule-out MPNs, it's even less than that, or even more than that. The number needed to test is 13. The other thing to think about, though, in this situation is whether or not a negative NGS result actually helps to exclude a diagnosis of MDS-MPN. In other words, is there some negative predictive value of these tests to help us really decide that, in fact, this isn't MDS or it is an MPN? And that's something to consider as well as we think about the appropriateness of using these tests in morphologically negative bone marrows. And I think the jury is still out on that, and we need to collect a lot more data and have more experience to help us decide that. So with that, I'll end and just acknowledge all of my current and former colleagues from Vanderbilt, some of whom are in the audience today, who have really helped us with this project. And I will take any questions. Thank you.
We have 2 minutes for questions.
Hi, Adam. That was a great talk.
Thank you.
I'm curious, in general, in terms of the onset, when you first put together the DMT, was there any resistance from the oncology side about sort of potentially losing control? Or was it fairly collegiate in terms of the actual onset of that?
Yeah, that's something that we worried about a lot. And obviously the clinicians, because they care about their patients, are reluctant to cede control over some part of their patient care to a third party, right? And so we worked really hard with the clinicians at the outset. That's why we involved them in the creation of the standard ordering protocols. That's why we set up methods to ensure that they knew what tests were being ordered and could follow up on those things, the informatics tools. That's why we gave them the option to order off SOP if they felt it was necessary. And by taking that approach, which we felt were sort of reasonable collegial things to do, we actually had a really nice working relationship with them. And over the years, they actually really like this because it takes something off of their plate that now they don't have to worry about. Right. So, good question. Thank you.
Excellent talk. Thank you very much. Very useful. Could you tell me, you said you worked for 10 years on developing this.
Yes.
So now the DMT, is it administered by one person, a group? Do you meet on a regular basis? Do you meet ad hoc? Or do you have, is it ongoing planning?
Yeah, that's a great question. It is ongoing. And about every year or two, we get together and we look at the ordering protocols and we think about revising them. And there's a couple of things that would cause us to revise. One is data that we've collected. You know, if we see that a test is proving not to be terribly useful, then we'll meet together and talk about in what particular situations might it be useful to eliminate that test. We meet together as we think about new testing modalities that come on that need to be incorporated. So about every year or two, we do a revision of the SOPs based on that.
So is it administered at the moment electronically by forms that are filled in? Is there one person that's overseeing that?
Yeah, so it's administered by the pathologist whose case it is, right? So the pathologist receives the bone marrow case, they look at the case, and they run the algorithms to decide what test should be ordered on that particular case. So it's done on a case-by-case basis, and the person responsible for that is the pathologist to whom the case is assigned.
Thank you.
Yeah.
Annette, we have to move on. It's 9:31, sorry.
We'll
You can
catch up
talk
in
to
that.
Adam.
It's okay. Thank you.
Thank you.